My name is Barbara Pasternak. I'm founder and chair of Diabetes Hope Foundation.
And I am Alex Colley, the program director with Diabetes Hope Foundation. And tonight, Barbara and I will be your wonderful hosts while we lead this amazing webinar tonight.
So this evening, before we begin, we would like to thank Abbott Diabetes Care for allowing us to launch our first webinar this season. And we would like to welcome Dr. Michael Vallis, psychologist and registered PhD and registered psychologist, along with our esteemed alumni as panelists.
So with that, as Barbara mentioned, we are joined by Dr. Vallis tonight and 5 wonderful alumni from various years of receiving their scholarship. So tonight they will be talking and sharing their insights on diabetes management, as well as their insights and expertise on managing their diabetes on top of having an additional health condition, such as celiac, seizures, learning disorders, nut allergies, ADHD, anxiety, and cystic fibrosis.
To address these very complex topics mixed in with having diabetes, we would like to welcome, as I mentioned, Dr. Michael Vallis. Dr. Vallis is a registered health psychologist who's based in Halifax, Canada. He's a health behavior change consultant and associate professor in the family medicine at Dalhousie University. His main area of expertise is adult health psychology with an emphasis on obesity, diabetes, cardiovascular risk, and gastroenteritis as well, if I could say it. We can understand it. Sorry. And how amazing that he recently was awarded the Queen's Diamond Jubilee Medal by the Government of Canada on the recommendations of Diabetes Canada. What an amazing honor. And we warmly welcome Dr. Vallis. So everyone put their hands together virtually and let's bring in Dr. Vallis.
Thank you very much, Barb. It's really a pleasure for me to present. As a health psychologist, I'm kind of a strange beast because I work in a medical field, but I have no medical competency. And so it's often difficult for people to know what actually I do. What I often try to tell them is I try as best I can to sort of represent the voice of people living with diabetes and other chronic conditions. So that's why it's really a privilege to be involved in a discussion like this. My hope is that I can bring maybe some hope to your struggles in both managing conditions and, unfortunately, also managing the health system so you can get your needs met. One of the things that is one of my research areas is what we call emerging adulthood. So how do you go from 18 to 30 when you're living with diabetes type 1 as you try to navigate those transitions? And how do you get care when right now there's very few care services that really are geared to support individuals in that? I'm very much a believer in empowerment and see that our job is really to make your job easier. Unfortunately, sometimes it seems like, it looks like, your job is to listen to us and do what we tell you. And I think there's the fundamental tension that I'd like to talk a little bit about. But I just want to sort of provide for people kind of a structure that I would encourage you to sort of view as a way that you might understand, first living with your diabetes, but then also in a more general circumstance, how to really promote health and wellness for yourself. So what I'd like to do is just really make some general comments. First of all, psychological issues associated with diabetes are actually not experienced by all. So one of the really important things that we have to appreciate is individual differences. That's why it's very difficult and why you should never really give advice, or if you're living with diabetes, have to be very careful about listening to advice because the diabetes has to be completely personalized to the individual's experience. That's why it's really nice to sit on a panel with individuals who have multiple diseases because they truly have to become the experts. And generally these individuals, when they get medical treatment, they actually know more about their condition than anyone else in the room. The other people in the room may be experts in various pieces of the puzzle, but not the whole thing. Very few people experience psychological issues with diabetes all the time, but many, many people experience occasional time-limited problems. So you can see there's a little bit of an inconsistency there. Sure, you're doing fine, and most of the time you do okay. but actually most people reach times when they struggle, and understanding and supporting those struggles are really important. And because maximizing the outcomes really requires overcoming those challenges. As I'm sure you would know, one of the things that we try to discourage, you see this sometimes in residents, where they'll diagnose someone with type 1 diabetes or other chronic conditions, and they kind of say, look, once you get used to this, it'll be normal, everything will be fine. And whenever we can, we try to jump all over those residents or any colleague who says that, because you really have to kind of embrace the difference and really to empower yourself. And I call this surrender to win. And so in essence, the challenge that we face is on the screen. And so it's so easy for us on the medical side of things to view diabetes as a biomedical disease. Pathophysiology is extremely well known. We've got all kinds of technologies to help us, and we've got all kinds of apps and guidelines. But at the very moment that it's a biomedical disease, it's completely a behavioral challenge. And so those are really two different points. So it's much more important that someone would to say to you, what is it that you would like to know? Or how is it that I could help you? Than it is to say, okay, today what we're going to do is review X, Y, or Z. Now, diabetes is a distressing disease. And as a psychologist, what I love about being in health is that we're not talking about people who have psychopathologies. We're talking about what is burdensome about the disease. And I say that because it's actually important that diabetes providers extend their comfort zone to address the issues associated with diabetes that actually bring burden on. And what do we know? What would make anyone's condition stressful, regardless of what that condition is? Well, how many demands are put on you for care? And the more demands put on you, the more likely you can experience the condition as overwhelming. And type 1 diabetes has, like, the list of behavioral demands just seem to go on and on and on. Maintaining glucose control is enormously complex. Do you ever really know why your sugar level is where it is at any given time? Or is it all seem a little bit like a guesswork to you? They're constant, and it doesn't matter how much you like your job. I know you like vacations. I know you want to retire. When you live with type 1 diabetes, you never get vacations and you never retire. It can be unforgiving. And my first work, I started working with diabetes and type 1 diabetes in particular around 1985. Now, I know that makes me very, very old. Do not try to do the math. But what I really, when I first started working, it was with young individuals who were experiencing serious complications at a very early age. And it was a very, very, as you could imagine, difficult scenario. And diabetes is plagued by uncertainty. Uncertainty breeds anxiety. So one of the things that I really would like you to take away is I'd like to normalize the idea of diabetes distress. This is one of the things that we're really trying to push with regard to understanding the lived experience of diabetes. And so we know that the condition has burden attached to it, and we want to normalize it. So some of the things that we talk about in Diabetes Canada is that at every visit, someone should be asking you about the burden of diabetes, the diabetes distress. Now, I say that to you because if they're not, ask them why not. Because when you ask them why not, you will create a teachable moment, especially if you do what I call blame me. So if they say, why are you asking? You can say, I saw this psychologist, Dr. Vallis, I think was his name, and he said that we should be asking this question. And if you don't like the question, you can tell him that it's not a good question to ask. And you can always use my email. Because in fact, we know that this is really critically important. There are 4 aspects of diabetes distress that we pay attention to. And I just want to walk you through. And really, this would be something that you could do a check-in with yourself every periodic time that every visit or once a month, or if you just want to reflect on how are things, you could check in with the emotional burden, regimen distress, provider distress. By the way, this one is my favorite because this is, excuse my language, this is the pain in the ass factor. What I mean by that is how much are we a pain in your ass? And this is what we call provider-based distress. And it's turned out that it's a very important aspect. And it's something that we health providers need to own because we cause it. And so it really falls to us to kind of manage it. Now, I hope you're taking from my language here that this is the language that's becoming normal in the professional diabetes centers. So if you feel shy to raise these issues, I just want you to know we already know that we're difficult. I ask my colleagues all the time, do you know that your patients experience you as judgmental? And they respond by saying, yes, we know, and that's why we invited you to this meeting. So it's not a secret to your healthcare providers. And then the final one is support distress, when you start to look at your world. And you very well know the people that you can kind of trust and the people you have to be cautious about regarding this. So when it comes to the emotional burden, if diabetes were a weight that you carried in a backpack, how heavy would it be? Half a kilogram bag of rice, a 2-kilogram laptop, 20-kilogram cement block, or a 500-kilogram car? I personally love that question because people answer it very quickly and it's very telling. It's really, really telling. And it varies depending on what's going on in your life. Overwhelmed, burnt out, and powerlessness. So these should be the questions we're asking you. And these should be the questions if your partner, your boyfriend, your spouse, your parent said, how can I support you? You can say, well, you could ask me these questions. Are you feeling kind of burnt out by diabetes? Rather than saying, come on, you can do it. I know, just hang in there. You might want to just kind of reflect on what the experience is, because this is what's really helpful. And it's what we see, especially amongst the type 1 individual. The typical person with type 1 diabetes is incredibly competent at managing their disease. And I don't know that we give enough credit to that competency. Regimen distress is about the management distress, the day-to-day tasks. But importantly, we know it's about eating distress and it's about hypoglycemia distress. I do a lot of my research on the issue of hypoglycemia distress, and we find it to be a tremendously underrated problem by healthcare professionals. Most healthcare professionals tend to only be interested in if you've had a serious hypo. Have you lost consciousness? Were you admitted to hospital? Did you have to call the EMT? Turns out that's the tip of the iceberg. When you look at the psychological impact of lows, they have a huge impact. And we really do need to support distress management, because the most normal response to a serious hypoglycemic episode is to allow your sugars to go high, because the safest way of avoiding another low is to be high. And so managing that, we call it compensatory hyperglycemia following a hypoglycemia episode, it's a psychological fear management, not a glucose management problem. Provider distress, I can't tell my diabetes doctor what's really on my mind. My diabetes doctor providers don't really understand what it's like. I don't get help that I need. And my providers do not know enough about diabetes or diabetes care. I'd be really curious. I'm going to kind of make a little plug here for the panel members, because the panel members, I understand, live with multiple conditions. So I'd be really interested in what the provider distress is like when maybe you have more than just the diabetes. And sometimes providers are very narrow. You know, I'm a diabetes doctor, all I talk about is diabetes. Well, you've got something that's maybe not diabetes, therefore I'm not so interested in that. So I'll just be curious, maybe they could comment. And then social support distress. And you can see that what we're doing is just indicating. So if you ever have any of these kinds of features, this is part of a really important concept, and we're hoping that individuals living with the disease can start to communicate this. Because one thing we know about doctors is if the patient raises the issue, the doctor feels responsible to take care of it. If the doctor's not comfortable with the issue, they won't raise it. It's what we call inertia, because they don't want to go into an area that they don't feel super confident in. But if you raise it, they kind of have to go with it. And so when it comes to sort of managing this distress, I'd just like to kind of touch base on thinking, doing, and feeling. And we know that these are different aspects of psychological functioning. And you can be helped by just kind of thinking about what do you do from any of these categories. And so really the thinking component is really to try to maintain a positivity. We hear about things like gratefulness. We hear things, if you want to improve your mood, do you want to know a really great way to improve your mood? A random act of kindness is one of the best ways to improve your mood. So looking for, more positive encounters, challenges, the doing part, keep connected, really try to find partners and learn assertiveness, because you're the one that's going to be the expert in how to manage your condition. And unfortunately, the way humans tend to interact is, if I care about you and I want to help you, I'm going to tell you what to do, which of course is the wrong way to support somebody, especially somebody who's actually pretty good at coping on their own. And then from an emotion point of view is really focusing in on pleasure. We know that change is hard, and we go through our lives trying to maintain sort of our health. And change is hard because human nature is you approach pleasure, you avoid pain. So apple pie tastes a lot better than apple. Getting up early to exercise sucks when you can sleep in. We follow the path of least resistance, and we focus on immediate consequences. A lot of the health behaviors you're going to be asked to do cause pain, require a lot of effort, and you don't see the benefit for a long time. So we have to recognize that. We live in a world where it's actually hard to focus on health, and that it makes it really difficult given the nature. So I'm going to quickly stop, but I want to show you how human behavior works. And this is our little brain here. And brains are what we call developmental organs. So if you just look at the brown, the green, the red, the blue, that's a way of representing various areas of the brain. As we have developed as a species, these brain areas develop, and they develop on top. So the new brain areas kind of sit on top of the old. But what happens in the brain, it's a developmental organ. That means that the old brain structure doesn't stop working. It keeps doing what it's doing, and you add on new features. So that means that we have two areas of our brain that control our behavior. We have our wanting system, which is this limbic system, which is a primitive system. That's how you feel. It's immediate. And then we have our frontal lobes, the very last thing to develop, not fully developed in girls until the ages of 23 to 25. And the frontal lobes are not fully developed in boys till the ages of 27 to 29. And that's why you see, young males doing all these crazy things. It takes a little bit of time before they start realizing that driving on the highway late at night after a couple of drinks in the rain with a motorcycle is actually not a safe thing to do. And so this is the nature. And I say this because what we have to do is accept that you're pulled in two directions. One of the things that I worry tremendously about as a psychologist is people who try to change, run into barriers, and then feel like failures, and then blame themselves and think, oh, I should just be trying harder. There's something wrong. Why do I keep falling back into this pattern? I know what I should do. I really do want to do it. Why do I fall back? And we do that in a judgmental way. And just as we know that if your healthcare provider judges you, that's not helpful, self-judgment is also not helpful. And so the purpose of this slide is really to show this is us. This is the human condition, this teeter-totter between do you listen to what you know you should do or do you follow what you want to do? And it really is important if we accept that we can promote self-compassion. If you can understand your behavior, that'll help you to your next choice. Finding motivation is really about asking yourself, why do you want to change? So it's not about health. Right? The exchange that will happen in the health system is, this will reduce your risk of retinopathy. This will improve your heart function. That's not what drives people. What drives people is the personal, meaningful reasons. Are you a family-oriented person? Are you an achievement person? Are you a thrill seeker? What do you want from your life? Who are you when you're at your best? And if you can link the diabetes care behaviors and see those as ways, the price that you pay to live the life that you really want to live, then that's where motivation comes from. Similarly, understanding that there's always barriers to change. And a lot of what I end up doing is trying to help people figure out how to overcome those barriers. That's what these types of webinars can really do. Listening to other people is a tremendously beneficial way of finding, your own personal strategies. And critically important is don't be shy about picking favorites. People that are dragging you down, be really careful about how close you get to them, because it's hard enough to stay and to keep motivated, and sometimes we have to be kind of harsh about who's truly a friend and who is not. We call them saboteurs, and what I'm talking about if you just sort of reflect on that.
Thank you so much, Dr. Vallis, for sharing. All the information was incredible that you shared. I'm sure our panelists have some questions burning in their minds. So Barbara, I guess we'll move on and we'll introduce our speakers, and then we'll let them ask their questions. So Kai, do you want to give a brief introduction about yourself?
Hi there. So I'm on Vancouver Island. I'm actually in my office. I'm a clinical social worker, which is a boring title for a fun job because I just meet with awesome humans all day of all ages and diverse backgrounds, from kids to older. And so I live with diabetes and ADHD.
Very interesting. Thank you, Kai. Kristen.
Hi, I'm Kristen. I am currently coming to you from York Region, specifically Vaughan. I live with, so long story short, I had 95% of my pancreas removed when I was only 3 years old due to hyperinsulinism, seizures, and as Dr. Vallis mentioned, hypoglycemia. And as part of also developing diabetes, I got such things as not being able to read my symptoms, learning disorder, nut allergy, and a reactive anxiety disorder. And I currently work with the York Region District School Board as a child and youth worker, working with kids with special needs, currently working from home.
You do so much, Kristen, with so much already to do yourself. Thank you for sharing. And Allie.
Hi, my name is Allie. I work with the Diabetes Hope Foundation. I've been working with them since 2013 when I received my scholarship. I'm from Ottawa. I'm 25 years old now. I live with cystic fibrosis and cystic fibrosis related diabetes. My educational background is communication studies and psychology, as well as a postgrad in brand management.
Awesome. So fascinating as well. And Janet.
Hi, I'm Janet, also coming to you from Ottawa. I am a scientific project coordinator for Health Canada. I've been living with type 1 diabetes for 25 years. So I was diagnosed when I was 18 months old. And I also have been living with celiac disease for the past 3.5 years.
Wow, that's a lot. And finally, Logan.
Hi, I'm Logan. I've been diabetic for 7 years now, and I was diagnosed with celiac disease about a week after I got diagnosed with type 1. So that was another learning curve all at the same time. I'm a DHF scholarship recipient this year, so that's really exciting, and I'm going into my first year of nursing school this year.
So lots already on the go. So again, thank you to Dr. Vallis for sharing your slides. And yes, please be sure to pass those over to Barbara and I so we can add them as a resource. So panelists, I'm looking at you all. So because Dr. Vallis shared so much interesting information, like I said, I'm sure all of you have some burning questions. So Kai, I'm going to start with you. Do you have anything that you want to ask specifically to Dr. Vallis?
Well, I was going to say I was taking notes, so I really appreciate this because I am at work and I'm taking a little break, but this is super useful for me, all this information, because I work with a lot of people that are struggling with this. So I love this, and being a human myself in my work, right? That we're all humans trying to help each other. So to help myself and others, I mean, I was just curious. This is pretty general, but if there's anything that's come up in literature or research or just through practice about the interesting nuances of living with ADHD and managing diabetes.
Yeah, so one of the really interesting things about I think where we are now, and it's I've been taking to call it the following: when behavior meets biology. So we're beginning to develop a better understanding of what's actually underlying from a brain function and structure perspective, the behavioral challenges. And so I'm hoping that what that will do is allow us to really figure out how to take a bit more of a compassionate approach. And so the reason for that would be, Kai, something like ADHD. So when you look at what's going on with ADHD, it sort of looks like what's happening is in that sort of frontal lobe executive systems. And so things are, the ability to sort of stay focused and sort of track, sort of working memory, and working memory would basically be, okay, you're kind of, you're organizing, your files, somebody distracts you and says, oh, can you come here for a minute? You go, and then you say, what was I doing? And, can you actually remember that, 45 seconds ago, you were actually working on your files? That's kind of, you have to hold everything kind of in this working memory. And with ADHD, that shifts a little bit. And where this is going is it's really helping us look at this in terms of then reframing how we help people. Because unfortunately, Kai, the relationship between the patient and the provider has always been like this. And sometimes you might have heard this. Doctors will say, I've got lots of patients who are able to do this. So if they can do it, you can do it. And that just completely invalidates individual differences and biological variabilities. And so as we start to understand, okay, hang on a second, that's not fair. You can't just ask one. And the way I put it this way is as follows, because this, by the way, is true. It is possible for someone to run a marathon in 2 hours, 1 minute, and 34 seconds. That's the world record. But that doesn't mean that everybody should be able to run a marathon in 2 hours, 1 minute, and 34 seconds. As a matter of fact, only one person has done it. But we have a tendency to think, well, if it's possible, then it should be possible for you. So one of the things that I'm hoping we'll be able to do is we kind of start to look at what are the limits of behavior. So when you have cystic fibrosis, what does that mean? When you have celiac disease, and you heard about gastroenterology, that's the sort of GI conditions. And so that's where we would see the celiac patients. So Janet, to be diagnosed with celiac, I'm sure you've seen a gastroenterologist. They were probably the doctor who diagnosed the celiac disease. But just imagine, the celiac disease sort of loves food that diabetes hates. It's a nightmare because the foods that make your gut feel okay are not necessarily the foods that sort of do well in terms of blood glucose, and sometimes it's kind of the absolute opposite. So it really provides kind of challenges. So for me, it's validating the limits of behavior, which then allows us to say, okay, given the fact, right? So what ends up happening is doctors kind of say, well, if only you got to try harder, right? Because this is the guideline. This is what you need to do. And we want to understand behavior such that we can shift, if only you could do this, to given that you have X, Y, or Z, what is the next plan? And it's that shared problem solving. The other new thing that's happening, and I think I'm hoping it's related to COVID, and that is because we're starting to understand that COVID is going to have an incredible mental health impact, that many people we're starting to see COVID more as a traumatic stress than just sort of a stressful life event. And so that's really putting increasing the sensitivity to mental health issues. So I've been invited to do a keynote presentation at Diabetes Canada meetings in the fall on diabetes and mental health, just because the group are saying we got to know more about mental health because we expect this. So ironically, this kind of negative pandemic event might actually increase our ability to support the journey. So I hope that was helpful, Kai.
Thank you. That was wonderful, Dr. Vallis. Just a segue into what you just talked about, COVID, mental health. Change can be very hard, and as most people know, especially those who don't have diabetes, find it probably more difficult. And we know that that we have to adapt to our day-to-day and healthcare routines due to COVID. With modern society, and sometimes encourages unhealthy behavior. Example, wanting to get fast foods when you have a long and stressful day. What are some of the strategies or solutions to help avoid this, to pull from unhealthy behaviors?
Yeah, so that's a really, really important. So it's my belief, because of the work that I do, and partly because of what we know about biology, that I'd like to suggest to everybody that food is a different behavior than any other behavior. And food is a different behavior. Eating does not belong in the same camp as any other behavior. I'd like to say that really clearly. And that is because eating food is actually really a biological imperative. And so the brain system has really developed so that, food is just so powerful. For instance, the following two substances. So I showed you that sort of limbic system in the midbrain and the frontal lobes, the emotional system. Well, that limbic system, that's where our pleasure centers are, and that's where addictions come from. And the following two substances light up the pleasure centers of the brain equally. And those two substances are sugar and cocaine. And when you compare sugar and cocaine head to head, sugar wins. So, and that's because, you see, the body is meant for survival. So we then have this drive to eat. So the two things here is first of all, to respect that, and to do two things. One is, what is driving your eating behavior? And the reason that I'm making a big deal about food as a special behavior, it's just so darn easy for it to be the reinforcement. It's just so easy to grab a chocolate bar, to look forward to a drink, food is just the easy coping strategy. And for every one of us. So the sort of psychological piece to this would be to say, hang on a second, if you're not happy with what you eat. So I like to say that eating is like a relationship, right? And I actually ask people, what is your relationship with food? And so, for instance, you can all diagnose yourself right now. I'm going to ask you a question. You're going to choose one of two options. Nobody can sit in the fence. So you have to put yourself in one of these two categories. You either eat to live, where food is fuel, or you live to eat, where food is a passion. You can't be on the fence. And now you know where you fit. And so that really tells us that sort of drive. So food is such a powerful phenomenon. What is it that would your relationship with food be? And here's a good relationship. Have you ever been in a relationship where you loved somebody, and she or he didn't love you back? Think about that. That doesn't work, right? So if you're eating foods and feeling bad about afterwards, that's like being in a bad relationship. You think you love the food, but if it loved you, you would be happy once you ate it. So this gets into all these emotional issues. And if we just kind of reflect and say, food is it's a trap. It's a sand trap. You can fall into it. We all fall into it all the time, right? And I'd say to you, I don't care what your attitudes towards Twinkies is, but if you had 2 Twinkies a day for 28 days, you would want Twinkies because you have a brain. So we sort of want to, and I call this replacing the function. So I've got myself in a pattern where I'm turning to food to manage my stress, and I'm not really happy with this. I'm not happy from a diabetes point of view. I'm not happy from a health point of view, but I've fallen into the trap. So what is an alternative function? So if you're managing stress, what are other stress management activities? And the other thing I would strongly encourage you to do is let's eat fast food. But you know what? A bag of carrots is fast food. Fast food does not mean junk food. Fast food means quick food. And a dietitian is a wealth of knowledge. You could spend 5 minutes talking to a dietitian and ask the question, I would like to access some fast food that would be healthy for me. Can you give me 3 or 4 things that I could do? And all you need is a couple of those. So when it comes to fast food, because remember, if all you're trying to do is fuel, fast food means we don't have time, we've got to eat. So we might as well eat good fuel, because then that'll keep our engines functioning well. We're not really, it's not a meal. It's not, you're not going out to, You're not going out to a graduation meal. You're not going to a family event meal where you want to enjoy. You want to be like an Italian and take 6 hours to eat the 12 courses, right? If you're going for one of those events, then you want to enjoy your food. But if you're saying, look, I just have to eat, then you might as well just kind of grab something quick, and that meets the needs. So that's how I would respond to that.
That's a great answer, Dr. Vallis. Thank you. And it seems across the board that everybody's received your message very well. And have to agree with carrots being fast food. I can just grab a bag and it's fast, it's food. So on the food topic, Janet, I'm going to jump over to you because I know that you had a question for Dr. Vallis. It might not be about food, but I know that you have celiac, so kind of made me think of you. So the floor is yours.
Let me unmute myself first. So as I mentioned, like I've been diabetic since very young age. So there's a lot of burden put on children, especially growing up, gaining that independence from that transition from parent taking management to now taking care of yourself. And then you add on that extra task of you're swapping to adult care, where quite often the endocrinologist or your team, they're used to seeing type 2 diabetics, or maybe they have some type 1s, not as many that have been diagnosed for so long. How do you bring up the discussions of distress and the burden that has been wearing down on the shoulders for 25 years?
Yeah, that's a really, really great question. I'll make a comment, and it may sound a little strange to you, but I'll explain it. So, do you know that the group of people who tend to get really poor health care are nurses? Do you know that nurses get really poor health care? Now, the question is, why do nurses get really poor health care? Because everybody assumes they know everything and they don't need any support. And so that's the connection back to you said, oh, you've had diabetes. Oh, well, then you're fine. And so it's really about two things. One is that we need a community to try to shift the conversation. People like me are really trying to do that. So I'm actually working on a beginning of an initiative with JDRF, where we're going to try to provide a training program for mental health providers in Canada, and we train them in what they need to know about diabetes so they can stretch into the diabetes field and maybe start promoting asking more questions. I would sort of encourage you to pick your battle, pick your time when you feel most strong, and then prepare a statement and say, I'm really nervous, doc, but there's something I need to say to you, and I'm just going to read it to you. And it might sound like, why haven't you asked me about how diabetes affects my health, my mental health? Again, blame me. Go on and find information from any health professional who's talking about this is important, and kind of bring it in. So I wrote a paper. It's actually the paper that I'm most proud of. I've published quite a few papers over the years, but that doesn't mean anything. But the paper I'm most proud of is a treatment for fear of hypoglycemia. And it's called, hypoglycemia. Fear of hypoglycemia is more of a fear problem than a glycemia problem. We published it with a group of people. I have a few colleagues in Europe. And it's the paper I'm most proud of for the following reason. I've given it to patients and they've given it to their doctors. So the patients have liked the paper. And then they've taken it into their doctors. And then they came back and said to me, this was really helpful because when I gave it to the doctor actually read it and found it kind of helpful. So it's making that kind of shift. I'd also like to make you aware, I have a colleague, her name is Dr. Molly Byrne. And she is equivalent to me. It's a sort of diabetes psychologist. She's from the University of Galway in Ireland. And Molly has led a program called Type 1 Now, and it's a participatory program about empowering young individuals with Type 1 diabetes, trying to navigate this very system that you've described. And there's lots of great stories and lots of great stuff. So again, I can make that available. I'll let Alex know the link to Molly's work. But people on the call, you know, if you want to kind of poke around, that project would be kind of useful, because it's very much about you know, really trying to empower the group to not feel that they're kind of you know, it's almost like in the health system, and you know, we feel like the adult healthcare system makes people feel like we're not interested in you, and so you know, ways of shifting that, I think, can be really, really important. Did that address your question?
Yes, it did. Thanks so much.
Dr. Vallis, we would love to get that information on Dr. Molly Bird. More information, more resources about this will help so many try to navigate their journey, of course. I just want to ask Ali, because I don't know if you have a specific question, but you have a very interesting background, CF and CF diabetes. I don't know what that means, but perhaps you can speak to Dr. Vallis in the audience about your question.
Sure, yeah. First of all, I'd just like to say, Dr. Vallis, thank you so much for every piece of information, everything you've said so far. It's so validating, and there is as a patient, I feel such a huge gap between, you know, your mental wellness and your physical conditions, and you're really bringing it together, and it's incredible. Thank you. And my question, so I do have cystic fibrosis and CF-related diabetes. Cystic fibrosis, for those who don't know, is a lung disorder. I was born with cystic fibrosis, and I was diagnosed with diabetes when I was 14, and the only reason I was diagnosed with diabetes was because of the cystic fibrosis. Growing up, I had an endocrinologist on one side and a CF team on the other, and it wasn't until I was 18 and transitioned to an adult clinic that I had this new CF-related diabetes team. So my understanding is that it's still fairly uncommon, and I'm just wondering if you've ever really come across it before, or how you help, you know, patients who deal with such conflicting physical disabilities.
Yeah. Thank you. That's a really important question, and I think my comment is that we actually don't do a really good job. We really kind of fail people in that situation, to be honest. And I think that, so what I would say to you, though, because the system doesn't seem to naturally want to put pieces together, you know, you know. So why is the Mayo Clinic so famous? Right? Everybody in the world knows about the Mayo Clinic. Do they have better doctors than at your local hospital or at my hospital? Because they actually don't. So why is the Mayo Clinic such a famous clinic? And I'll tell you why. If you went to the Mayo Clinic, here's what would happen. You'd be seen in the morning. It would be determined all the doctors that you would need to be seen. You'd see those doctors one after the other in the morning. Then in the afternoon, you would have all the tests that you would need. Then tomorrow morning, all of the doctors would get in a room together with all of the tests, and they would invite you in. And as a team, you guys would figure it out. That's why the Mayo Clinic is famous. So I say that to you because what I try to do when I have, when I'm involved with individuals like yourself, is try to create a team. So I would suggest to you, who's the point person? So who's the person on your team who you feel, and listen to the response, listen to this, who you feel most close to, and who has the most power. When you get into the medical system, we all know it is a power-based system. And so you got to have somebody on your side who has sort of more power. So it's usually a physician, but you know, you find sort of a pivot person, and then you work with that person to say, how do you bring everybody together? Because if you have a medical support person, then, and you can work with that person and team up. And it's like your job is to get everybody in a room at the same time. And I have to tell you, that is incredibly difficult. I find that we work literally, Ali, months to get a full team meeting. but do not give up. The strongest predictor of success is not giving up. And so I would just say, if you had a person who, and because nobody's going to disagree with you. You see, nobody's going to, write on a chart, there's no way this patient deserves to have integrated care. Oh, there's no way that Dr. X has to talk to Dr. Y. That's completely against any approach to clinical management. We all would do that. And so it's just not giving up. And so what happens, we often have, one doc cancels for one meeting, somebody else can't make the next meeting. But after 3 or 4 tries, it happens. And it's worth it. Because then for one patient, yourself, right, it'd be great when you have this kind of combined clinic, it's awesome. But if you don't have the clinic, if you have this sort of ability to create your own team meeting, we only find that you don't have to do that very often before now all of a sudden things are kind of integrated. And that can be really helpful, especially because in the team, it'll be a little bit easier for your voice to be heard, because there's all these multiple perspectives. So no one, if there's a respirologist and an endocrinologist and a family doctor and your voice, nobody's going to dominate that, because the family doctor is not going to let the endocrinologist dominate it. So you kind of can use that. So that's what I would suggest to people who are in this situation, where they could advocate for a team meeting. They're very helpful.
So we want to thank you and to you and our panelists this evening, and for sharing your valuable insights and for your personal stories, panelists and alumni. We adore you. We also want to thank Abbott Diabetes Canada Diabetes Care Again, who has allowed us to have you here, Dr. Vallis.
It's great to have you on the panel. Thank you so much, guys.